Well, hello, everybody. My name is Garrett Schmidt. I am the CEO and managing editor for VBC Exhibit Hall. And I'd like to welcome you all to today's live webinar hosted by CareJourney, which is an Arcadia company. And it is called Mastering Value-Based Care Networks, Insights for Competitive Edge in PY 2026. We've got a lot to cover today, so I will turn it over very soon here to our speakers, which I will introduce momentarily. A couple items of note before we get started. This is a traditional webinar format, so everyone has joined today in listen-only mode, so you don't need to worry about turning off your camera or your microphone or anything like that. We can't see you or hear you. However, we do want to hear from you, and we are going to have a time for some Q&A towards the end. And we're also going to have a couple polling questions that you can participate in that are anonymous. But it'll be fun for the audience, and you guys can see also kind of where you stack among your colleagues. If you have a question at all for either of our speakers anytime during the presentation, feel free to just go ahead and drop that question into your control module. You have a little spot that's for questions specifically. We're going to get to as many of those as we can. We do have a big audience today, so if we don't get to yours for some reason, don't worry. Someone will reach out via email to make sure we answer your question. And finally, the session today is being recorded. So what's going to happen is about an hour after we conclude, you'll receive an email, and there will be a link in that email to where you can review the session, the recording, and or download the slides. And that way you can review it at your own leisure and or share it with colleagues, and we hope that you do. So without further ado, I wanted to very briefly introduce our speakers today. With us, we have Mr. Zach Bredl, and he is the Senior Director of Products with CareJourney. And we have Mr. Jeff James, and he is the CEO of Wilmington Health in Wilmington, North Carolina. So welcome, gentlemen.
Yeah, thanks, Garrett, and definitely echo what Garrett said about thanking you all for being on today and taking this time to listen to us. So, as you said, I'm Zach Bredl, a product person here at CareJourney. I've had the pleasure of being part of the CareJourney team for over 6 years now. I've bounced around a few roles, but currently leading our product team as it pertains to value-based care products. CareJourney as a whole, for the background, for those of you who don't know, we are an arm of Arcadia that is very focused in value-based care market intelligence and kind of provider performance in general. We got our start working on ACO-specific claims files, but have since graduated into working off of national Medicare fee-for-service, Medicare Advantage, and even more commercial data sets. The role at CareJourney has allowed me to get pretty close to a lot of really smart individuals, a lot of you who I know who are on the call today. A great membership we have here at CareJourney. Jeff, who's joining me today, is a newer CareJourney member, but certainly not new to the value-based care landscape and building networks within value-based care. So excited to have him on the call today. Jeff, do you want to give a brief introduction of yourself?
Yep, Jeff James, CEO of Wilmington Health. Pleasure to be here. Thanks for inviting me to do this. It's fun to talk about our story and some of the things that we're working on, and certainly CareJourney's been a really nice add to our portfolio of data and information that we use to build our networks across the country. So thanks for inviting me, Zach.
Yeah, of course. So what are we talking about here today? I think this data here does a really nice job of setting the stage of why networks are important and why we need to have this discussion today. So kind of one of the core analytics that we focus on at CareJourney is this idea of observed to expected ratio. You can basically think of it as like based on your population for a given metric, what would we expect the outcome of that metric to be? And then once we see a performance year happen, how does that actually pan out? So, did you perform above or below that lever? So what we've done here on this slide is taken the 2023 ACO REACH performance, and we've essentially carved out the ACOs that are kind of the top 10 savers, so the ones who did the best in the ACO REACH model in 2023, and then separately ACOs who had losses, so kind of missed the mark compared to the ACO REACH set benchmark. And what you notice here, and I'm going to draw your attention mostly to the O to E column, which you want to be lower. Lower essentially means better performing. is it's not it's not abnormal to see that on a PMPY on a cost basis that the top savers obviously did much better. But what we see here is when we look at further metrics like complications, length of stay, mortality rate, ED, kind of these more core utilization and medical economics metrics, is that the top savers performed much better than expected in these metrics as well from an ODE perspective. Now, I mean, you can think about this as obviously there's some difference in how these networks practice, but there's also a core difference in the culmination of these networks, the networks that are put together. So that's kind of the difference that you're kind of shooting for in terms of success that we want to make sure to run through in these various scenarios. So before we get into kind of our core part of our presentation, which is going to involve a few example scenarios that Jeff has laid out, kind of real world scenarios, blinded, but things that were actually relevant to his work at Wilmington Health. We think it's important to understand that most folks on this call are not in the same part of their value-based care journey. A little bit of pun intended there, but some are just starting evaluating, hey, is going into a model like MSSP or joining an existing ACO REACH entity, is that in the cards for me? Is that is that something I should move forward with? Are there going to be a lot of policy changes coming up in the next couple of years that I need to worry about? Where others have been doing this and been part of one of those programs or doing this on the commercial side for 10 plus years. And that doesn't mean that you don't need data like what we're going to show today to help you on that journey. It just means you're going to use it in a little bit of a different way. So we're going to kind of make sure and keep in mind as we're going through this process or this webinar to kind of talk towards those different stages. And I think just leading up to that, I'm going to call Garrett back here real quick. We're going to take a short poll to understand kind of like what the audience is that joined here today.
All right, so you will see up on your screen a question. And this is an anonymous poll, by the way, so feel free to participate. And we're going to show the results here. But where are you on your value-based care journey? Haven't started? No, we're just beginning. We're looking to optimize, or we're scaling a proven model already. So we'll give you a second to respond here. And then, again, we will share the results. See where everybody is. So we've got about, I think we have the majority of responses. I'm going to give it about 10 seconds and then we'll close it down. All right, I'm going to close it in about 5, 4, 3, 2, and 1. And let's go ahead and show the results. All right, Zach and Jeff, are you able to see those results on your screen?
Yeah, able to see it. Yeah, it's a great mix of organizations here. Definitely seems like we're skewing towards some more advanced organizations of either close to optimization or looking to scale out a proven model. But I think definitely helpful to say and exciting to see that we have about a fourth of the attendees that are kind of early in the journey of either having started or just beginning. So I think that there's valuable information across the scenarios that we're going to go through here. And with that, I think, Jeff, it'd be great for you to kind of intro Wilmington Health a little bit and talk about, one, I think dovetailing off of that comment, where you are at with Wilmington Health as far as your stage in value-based care, and then potentially, what has that journey looked like and how has that changed from when you just started or were just thinking about some of these models?
Okay. Yep. Thanks, Zach. Again, really thrilled to be here. Like talking about our story and the things that we're working on. So Wilmington Health is, I think it's the largest independent multi-specialty group practice in North Carolina. I think probably we're also likely one of the most sophisticated. We've been working on value-based care since really 2009. And where we made that switch is we went to a conference and listened to Don Berwick talk about the triple aim and recognizing that fee for service was likely to change. So before that, we were obviously heavily steeped in fee for service and continued on that way for a long time. We became the first commercial ACO in North Carolina in 2012, joined MSSP in 2013, stayed in MSSP until we got into ACO Reach in 2023, I guess, or 22, whenever it started. We've had really strong performance since we started early. We've always been, really, really high in quality. So on these graphs, it's just a few that I picked out over the years. The goal is to be as far to the right and as low as possible. And you can see, year on year on year, we've had really good performance. Go ahead, Zach. So our next, this just kind of shows where we are now. And my friends at CareJourney allowed me to throw in a plug for our ACO. So if anybody's looking for a 2026 Reach platform, we'd really love to talk to you. And in addition to that, we also own a clinically integrated research clinical trials company that we use as a value-based care countermeasure. So if any of you guys would like to see the intersection of clinical trials and value-based care, also love to talk to you. As far as where we're at right now, we have one of the largest ACO reaches in the country. We're fortunate to have some really, really good partners in that ACO. Right now, we actually have, in addition to that, we have another ACO, which is an MSSP Track A, where we've got a few partners in it that we're trying to help tune up. They're not quite ready for downside risk at this point. In total, it's roughly 150,000 members. I think that's actually a little bit low now. You can see from the quality perspective, our ACO reached maxed out quality, so that's consistent with all of the other years that we've been in either the MSSP or the REACH program. Our savings rate in 2022 was about 13%, overall in 23 about the same. Wilmington Health specific savings rate, though, was about 18% for 2023, and we did gross savings of 156.5 million, which I think 2024 performance is going to be a little bit higher than that. So obviously, it's pretty good, amount of savings per patient. Zach?
Jeff, how have the kind of like expectations of your organization as far as like savings and quality percentage changed from like 2013 to 2023? Was it always an expectation of 10% plus savings? Is that what you think year on year now, or is like 2023 just a really good year and you can't expect that every year? How do you think about that?
Well, it's not just 2023. We've
Yeah.
been above 10% for a while. I can tell you though, like it's a really good question to ask, like what was it in 2013 when we started this? Honestly, our culture wasn't there yet. And we were still mostly focused on fee for service. And then some of us were running around talking about this, value-based care thing and pop health. And I think our physicians got tired of hearing about it. But one of the things that they reacted to really, really positively is when we posted all of their quality scores, completely transparent for everyone, including the patients. So the patients got to see doctor on doctor quality measure by measure, and that's really what drove the quality side of our culture. And now, though, it's just who we are. It's not bolt on anything. It's woven into the fabric of the organization, and so almost. I think it's about 80% of our business is at total cost of care downside risk. We have one really unique partnership that I think is probably one of the only ones like it in the country, probably maybe the only one. And that's a partnership with the state of North Carolina, where we are with a partner. We are taking total cost of care, upside downside risk on a geography of patients. Many of those are not attributed to us. So we're responsible for all of the state's employees that live in a 4-county area. And again, we only see about a third of those, but yet we're still taking downside risk and responsible for quality and outcomes on the whole population, which I think is a little bit unique, and probably, the next phase of those of us that really want to make an impact in this value-based care space.
You'd say that's probably more towards the kind of like advanced end, like you're confident in your model. So this sounds very similar to, like, for some on the call, I'm sure you remember when direct contracting originally came out, there was a
Right.
geography proposal of that. Is that kind
Yeah,
of like what made
that's
you
it
think of this?
exactly. It's the geographic sort of component of
Yeah,
direct contracting. Yeah, that's right.
right.
I don't know if they had any takers on that, but we're doing it for
They may have to
commercial.
begin with, but yeah, and they may soon in the future. Okay, I'm excited about some of these examples, so let's move into those. Um, so this first one, obviously there are a lot of orgs on the call, including yourself, Wilmington Health in general, that has affiliation with a health system of some sort, or might be starting a new ACO that is affiliated with the health system. Talk us through this example and kind of how you think about, what the title says, maximizing value and minimizing risk for that situation.
Yeah, so I'm going to show about, I think, 4 examples, real life examples. These are things that we actually did and presented to clients or prospective clients, based upon, the whatever that particular client asked us to do. We do a fair amount of consulting as well. And so in this example, we had a prospective client ask us to analyze 2 health systems that they had relationships with. And this is one of those, one side of that. And so the first thing we did was we took a look at modeling the entire physician group of that health system. And even though they weren't in a value-based program at all, they were achieving a really high savings rate. And again, not in anything. So we use the CareJourney data to kind of surface this data. And then part of the thing that we were trying to talk to the system about is, a maximization problem. Like, okay, there's one thing on how would you do, but how do you measure that against the risk? Our organization is relatively risk averse, so we try to only do things that we're really likely to be successful at. And that's the point that we were trying to make to, this particular potential client. So we analyzed the group. They were hitting about an 11% savings rate, which is tremendous for not being into a program. But if we were approaching that health system to be one of our clients, it would still make us nervous that they hadn't done anything or didn't appear to have been doing anything in the past. And so we would want to get them on a journey, but how would we go about doing it? And the way we would go about doing it is we would probably stratify it. So we would take the top, and in this just example, we took the top 10 performers and we said, okay, if we put the top 10 in our reach, and then we started working on the others and tried to bring them along sort of as a year 0 approach. And over time, we could start moving more and more into reach. What would that look like? And so you can see the top 10 performers, their savings rate would be 22%, and their total spend was 13.5. So when you look at the savings rate of 22% against a 13.5 spend, your downside risk is very, very low. And that's if we were taking on this group, that's how we would propose that we did it. A multi-year phase-in approach, minimizing the risk, and still maximizing the percentage of savings as best we could.
Does your recommendation change if this is like evaluating participation in like a lower MSSP track or like an upside only model, or is that part of
100%.
the Like, is that part of the equation here, or was this scenario particularly like focused on entering reach at some point?
Yeah, well, and the reason for that is, you can't just take 10 and put them into a new ACO. You'd have to put them into an existing ACO,
Yeah, for reach
but you
here.
could put them in reach.
Yeah.
And you know the but absolutely, if depending on how this group was split out, and I don't recall, but
Mhm.
if there were opportunity to do a separate MSSP or bring those others in so that we could start getting, the data real time or much closer to real time, um, then we would want to do that, start getting them used to seeing it, seeing the reports and things like that. So definitely, that's one of the things we talk about, and I might even talk about that while we
I
are
think
here.
that leads into your next slide, kind of
Yeah,
the evaluation against, that's
yeah,
really three flavors in this point, but you could probably even break it down into tracks within an MSSP and not just retro and
yep,
prospective. Yeah, I'll let you
yep,
continue the thought here.
yep. That's right. Perfect segue. So this is another example for a different potential client of ours, and what we were showing them is strategy around how to do this. And what we did was we took um, the top 10 providers and just tried to make an illustration in their organization. And we said, okay, how should we approach this? And it turns out that, so we looked at it, MSSP prospective, MSP retrospective, and then REACH. And this group was actually in a REACH program. So their savings in REACH, was projecting out for 2023 at 1.1 million. It's pretty good. Um, But then what we said was, okay, now let's maximize for the individuals, for the 10, and which programs should they be in? So by maximizing for the individuals, and again, it's supposed to be an illustration of what you could do across all of your books of business. Um, and you find out that if they maximized by putting them in different programs, they would end up with, a significantly higher savings rate overall.
Yeah. I think that's really powerful, and a lot of that relies on understanding the differences in core methodologies amongst the two models, right? Which I'm sure you and your team pay a good amount of attention to, especially like the year on year changes of like what's defined for the changes for 2026. But maybe like, we laid out a few here. Can you talk about how your team stays aware of those? I also see you put in a regional efficiency factor here. Like, how does that play into the evaluation?
Yeah, it's sort of like all things, and the
Yeah.
regional efficiency factor. We just wanted to show, like, okay, against the region, how are they
Yeah.
performing? That would actually be a good one for the last slide when you're really uncertain about the organization. How are they performing? But we used to, try to get the actual claims extracts. Um, but I will tell you that using the CareJourney data, um, and they're not even paying me to say this, makes this analysis a whole heck of a lot easier. Um, this is stuff that we can whip out now at such a faster pace than we were ever able to do it before.
Yeah, well, we appreciate that. We've certainly come a long way, but even some of these views of grouping up things and simulating groupings across is are views that we can make more easily available to you than you having to do yourself. So certainly we'll work on continually to improve those throughout our partnership. Okay, let's get into this next case. I think here we talk about, you highlighted in the previous slides, like just straight taking the top 10 without doing any further thinking. And I think that for like the more, again, organizations just starting out, like that's a good first cut, right? But I think here you have a little bit more detail on what organizations may be considered having good or quote unquote bad attribution and why. So
Yeah,
expand on
so
that.
this is a client that had multiple ACOs. They had 4 ACOs. Um, and one of the things that we were showing them is they don't appear to be managing their attribution very well across the various tins that they had. And so if you can look at this ACO one at the top, you'll notice at the top line they had their primary care clinics in there and performing pretty well, doing fine. That's the lion's share of the attribution, and saving a reasonable amount of money PMPY. But then after that, you start to see some areas where we wouldn't recommend that they put those TINs in an ACO because of the likelihood of negative attribution. So you see they've got a cardiology group, the continuation of that, the vascular institute, the hospital, urgent cares, um, and whatever this digital care group is. But we would say that for most of those that they have, and obviously I didn't take them all, but I
Yeah.
cherry picked the ones that didn't look very good. Um, we would not, in any of ours, we would recommend leave those tins out. Yes, I know that you probably own them, but not everybody needs to play.
Yeah.
And in a maximization problem, they really missed the boat on that. The next one, same thing, ACO2. They have a medical group that performs pretty well, but then they have a hospital in there. Not a lot of attribution, but it is really, really negative attribution. And again,
Hmm.
we would suggest that they exit that 10 from their ACO. The third one is an interesting, I think it's a miss on their part. They had another ACO that had, it was MSSP, it had a low attribution and therefore had a minimum savings ratio that they couldn't get over. So even though their ACO saved money, it didn't cross over the minimum savings rate that they needed to, and ended up with none. If they would have just stuck those tins in one of their other ACOs and paid an actuary 30 grand or whatever the number is to carve it back out, they would have made an additional, like, I forgot what it was, but let's call it 1.1 or 1.2
Yeah.
million.
Yeah. Yeah. So I think a lot of what I'm hearing here seems to be that, especially specialist groups, as well as potentially hospitals, can create kind of attribution that from an outcomes perspective can be quite variable. So that makes it a little bit more risky to include those. One thing I've noticed and had a question for you on this is um, sometimes hospitals, particularly like CCNs, as part of being the ID as attribution. I think a lot of us, network building nerds know that. Sometimes those particularly have a very significant amount of attribution. So in that perspective, like from a revenue point, you don't want to leave them out. Like when can you be confident in including a hospital or a CCN as part of it? Or maybe is that something you would test out in an upside only first to just ensure that there's more comfortability?
Yeah, you would, but you would definitely try to, if you could, keep
Yeah.
them out of a downside when you don't know.
Yeah.
And like, let's just talk about this cardiology group, for example.
Hmm.
It's likely that they're getting a ton of attribution managing patients that aren't their primary cares because they're probably taking all comers from a very
Yeah.
large region, and those patients are going back to wherever um, their primaries are, but yet the attribution then stays with that 10 because they saw more of their cardiologist than they did their primary care that year. Um, and so, like any single specialty group, that especially the closer
Yeah.
it comes to a monopoly in the geography, is suspect for having poor attribution. If it's if
Yeah.
if uh, if the referral patterns are such that most of that specialty group is seeing
Yeah.
the primary cares that are in the networks more likely, then it's
Yeah.
okay. But the closer to a monopoly in a region, the worse it's going to be.
Yeah, there's almost a metric that you could think about of like strength of attribution to who you're attributed with. Like,
Yeah,
are you attributed because you've spent 10% of your dollars with that group or 50%, right? And I think that would scream for that cardiology group, hey, like they're really spending very few dollars with this. This is just like they've limped into attribution there, if you will.
yeah. The interesting thing, like I think you made a comment on the revenue. I don't know that that's. for us, that's not necessarily one that we're looking at.
Yeah, I
It's
think it
really,
was less of revenue and more of more patients to get savings multiplier from, right? Yeah,
yeah, the, it's just you have to know where it's coming from and why are
sure.
you getting that attribution. Um, and because if you don't know that, then you can't manage those patients. And are they really your patients, or did you get really bad luck in getting them attributed to you this year, and they're going to be with you um, and drive that down? Like, do you, again, for us, like very risk averse, we're going to take
Yeah,
like the most conservative
no,
approach
makes
and try
sense.
to maximize, the savings against the associated risk of that savings.
Yeah, for sure. Cool. Well, let's hit another example. So, we talked, I think a lot of organizations here probably feel really good about their core market, right? Like you guys, for example, you've been in Wilmington, North Carolina, worked on contracts there for a while. But a lot of organizations here are, kind of like yourself, trying to expand at least regionally, if not nationally, right? How do you think about addressing a use case of entering a brand new market that you have no kind of sense of?
Yeah, that's what this is. So someone asked us to analyze a market and suggest a strategy on how we would approach it. We analyzed a market that had very little value-based care, but there were some, and the risk that we saw was fairly significant compared to some of the opportunity in a relatively unmanaged area. And so the way we would attack this is we would try to find a few groups that were performing very, very well and get them as anchors first. And that's what this example is. We identified a few providers across three groups that looked like they had a fairly large savings rate and were doing pretty well. And so we would go after them, and then we would look at, relatively low opportunity there, not a lot of attribution, but from that we would build upon it and then go after some that might be a little bit more um, risky or less managed.
And is
And
that's what you're showing on this slide
yeah,
here?
that's what this slide shows, the same market. Um, and the way we characterize these is ones that, okay, yeah, these we could probably talk to, maybe get them into a year zero where we're building them up in an MSSP track A. The yellow is questions, don't understand them, and the red is we'll talk about that a different day.
Yeah, yeah, understood. So yeah, I totally understand the like finding anchor within the community and having confidence in that before you go to these kind of like non-VBO, non-participant groups. How much do you put stock in like the ability to coach these organizations or help them improve? Like do you say like when I especially looking at these like metrics like IP per 1K, avoidable ED, like are those things that you go in and are like, hey, with our experience, like we could probably help them a little, like they're in the like no savings right now, maybe they're level, like with a little bit of help from us and our experience, we could get them to a 5 or 10%. Like how much do you think
Yeah,
about it that way versus just buying in on what they are?
that's huge. It's juice squeeze.
Yeah.
And like I honestly think this is one of the areas that is overlooked by lots of people that are trying to build clinically integrated networks or value-based care programs, or even some of the national conveners or aggregators. Like they're just looking for the numbers, but they're not assessing the cultures. And if the cultures aren't ready for it, the uphill push is significant. And we would skip it or talk about it over a long amount of time, um, or put them in a track A and see how it goes. But we have limited resources, and so we prefer to talk to people that are at least um, somewhere have thought about it and understand what the culture needs to be.
Yeah, I think that makes a lot of sense, and we've heard that from a lot of members throughout the CareJourney organization as well. Of if if someone you're adding in your network isn't willing to invest and wanting to be in the this kind of like push to value, then it's likely to turn out in a not so great both financial and financial state for you in general.
Yep.
Cool. I think we're going to hit one more series of examples here. So, this one, I think we talked a lot about specifically MSSP and ACO REACH and those value-based care models within the Medicare market. But I think it'd be good for everyone on this call to hear about using some of that data and contextualizing it with some outside Medicare data to help you with commercial-based models or kind of like the combination of lines of business.
Yeah, this is one of my favorites. And the reason for that is we're using the Medicare data to apply it against other kinds of strategies. So in this case, one of the things that we were looking at was a couple of different providers and two different health systems in the same community. What we looked at was, okay, what's the inpatient spend versus what is, I got to back up.
You're good.
Sorry. Okay, so we're looking at two health systems, and then what we did was we looked at a independent physician group, and we used the CareJourney data to analyze the referral patterns of the independent physician group into these two health systems. Okay, so now I've got the setup right.
Yep.
So the idea was to come up with a alignment strategy for this independent group for one of the health systems. And so when we analyzed it, we saw that the vast majority of the work from this independent group went to system number one. And we found that to be true in inpatient and outpatient, as well as just the physician group. If it were a referral, it went to the system one's physicians. And we verified this by looking at the hospitalists. So we found that true enough, the hospitalists of system one got a whole bunch more than the hospitalists of system two. And then to find a specific opportunity, we looked at cardiology. System one was getting all of this group's cardiology that they didn't do themselves. And so the goal is, okay, how do we develop a model that will help system two be more competitive with this independent group, a true physician alignment strategy? So go ahead to the next slide.
Yeah.
So here's where we pulled in some data that's not related to the CareJourney data, but it enhances our ability to do this analysis. And so we have access to all of the fee schedules for all of the providers for the entire state of North Carolina. We know what everybody gets paid by everybody else. And we also have, several other states that we could do that too as well. But in this instance, what we did was we looked at their commercial fee schedules across Blue Cross Blue Shield, United, and local regional one called MedCost. And so if you track with me on this, in the top, let's just look at the Blue Cross example. What we found is that the physician group's office visits were pretty competitive against the systems. Made sense because it's a primary care group for the most part, but they did have some specialists, and where their fee schedules were really subpar was in their procedural areas or with their specialists. So they negotiated really, really hard for E&Ms, and for everything else, not so hard. So we found that if you look at System 2's reimbursement for nuke scans, for example, you find that their scans are significantly higher than they would be for the physician group. So what we suggested, and also this group did not have an EP doc. The system has like 10 of them. So we suggested that why don't we talk about approaching this group and putting an EP doc on-prem, one of your EP docs, and two, let's talk about doing a PSA with this group for cardiology services so that they can take advantage of your higher fee schedules in cardiology. And oh, by the way, you're not getting any cardiac caths whatsoever. So why don't you talk, this is a value-based care organization. So why don't you talk to them about joint venturing and ambulatory cardiac cath? And then also talk to them about bundling and how they could use that as a strategic opportunity to go direct to employer. So I like this. It's really kind of neat opportunity for us to work with some of our clients. It allows for using the claims data, the CareJourney data, but then augmenting it with other market knowledge to come up with a overall strategy and find opportunities that the health systems or whoever you're working with, or whatever your use case is, if it's even for yourself, you didn't even know were there or could have been there.
I really like this way of thinking because I know that commercial data, at least aggregated at a level that you can truly draw insights from, is near impossible to come by, at least in a lot of geographies throughout the country. So being able to essentially correlate the Medicare data, be that fee for service or Medicare Advantage, with like something that you can actively do on the commercial side, I think is very smart. Cool. I know
we're kind of pushing on time. We can probably skip this last one.
Skip this
more
last
of the
one.
same.
Okay, cool. So I think those were the examples we wanted to get through today. We definitely, Jeff and I want to hear from you guys as far as the questions. So I'd advocate for you to, if you have a question, to use this time to enter that into the questions functionality. But before we do that, we want to know from you one more poll question, and I'm going to lean on Garrett to hop back in here. Is what is your biggest opportunity to apply data for? I think this is actually for PY26. So for looking forward to roster building for next year. So got an option for some answers here.
All right, so this should be up on your screen now. And yeah, again, this is PY26, I guess this should read.
Yeah. And Jeff, maybe while this question is going, like, I wonder if you could talk a little bit about like timing of roster building, right? And you think about, like, obviously we're barely into 2025, but roster submissions for 26 come up they come up on you in the summer, right? So is like kind of how does your organization go about what time of the year you do type of analysis, and does that vary for like your commercial contracts or MA contracts?
Yeah, I mean, obviously right now is the season to be working on opportunities for 2026, because, it unfortunately ends, like you said, I think it's in June. And so the opportunities for 2026 are happening now. So again, as any of you guys look for ACO REACH partners, feel free to see my email and contact information at the end. Another shameless plug that you just kind of tossed up to me, Zach. I appreciate that.
Love it.
There you go.
But no, I mean, really now is the season that we're looking at different opportunities with, different potential partners, and trying to be ready to have, whatever offerings we're going to have out, obviously by the deadline.
Yeah, great.
All right. I'm
Eric,
going to go ahead and
you
show
got
the
enough
results
answers?
here.
Yeah.
I think. All right. Are you able to see that on your end, Zach and Jeff?
Yes, able to see. Jeff, looks like people really liked the last example with 52%
Yeah.
wanting to get into utilization and referral optimizations. That's an awesome signal. And I think it also means that a lot of this stuff in the earlier session, hopefully people feel very confident about the data that they have access to and are able to use alongside that. So I think that correlates into one offer that we're going to make as CareJourney, regardless of if you're a CareJourney member or not, is offer you a set of complementary data that is very similar to what Jeff showed throughout these scenarios today. So if you're looking for specific utilization data of a specific group to a health system or vice versa, that's something that we can work with you to kind of give as an offer for a thank you for joining this webinar today. If you're interested in that, versus not using the question functionality, but instead using the chat functionality, if you can type yes into there, that'll help us be able to prioritize to who to follow up with. Also, post like emails and such kind of in later slides, and it will be sent to you. So there are other ways to get in contact if that's of interest as well. last thing to mention here is if you enjoyed this webinar today, if you enjoyed hearing some smart folks in value-based care like Jeff talk, we do plenty of these. So there's a full series of these coming up. So would love if you guys would register for that and to have you attend those as well. Cool. So with that, I think we're going to call Garrett back and see if we have any questions from the audience that would be good for us to answer.
Yes, indeed we do. And if you have a question for either Jeff or Zach, go ahead and drop that now into your module using the question functionality there. And we're going to get to as many as we can. If we don't get to yours for whatever reason, don't worry.
We'll
Someone
follow
will
up.
reach out to you. Yeah, we'll definitely get back to you. We have a big audience today, so we're going to get to as many as we can. In no particular order, let's go ahead and dive in here. First question is this. What are the most important characteristics of data when trying to plan for an upcoming performance year?
Yeah, maybe I'll start, Jeff, and you can comment as well on your side. So I think we hit like what was shown across all slides pretty much is the difference between a modeled benchmark in an ACO REACH or an MSSP program and the actual year PMPY performance. That like delta that creates a savings or loss number, like that is core, and making sure that is produced to the specs of those methodologies is very core to any of your modeling. So I think that's kind of like the starter perspective. I think where my answer would go as far as beyond that, what's important is a lot of the like peripheral information about the practice group. So have they participated in an ACO in the past? What parent group was that associated with? Have they had a lot of influx of physicians or outflux of physicians within their TIN? Kind of like what's been happening with that TIN. I know that there'll be a lot of there's this whole other bucket of utilization and quality metrics, but maybe that'd be my answer as like the number two thing that a lot of our members look for. I don't know what you think about Jeff.
Yeah, no, I think that's spot on. And if to the next phase of analysis, it would be, where's the low hanging fruit and how hard is it going to be to action that? So is it ED visits or site of service or is it
Yeah.
RAP score? What program are they going to go in? Are they going to go in by themselves? Are they going to go in with someone else? Or are they going to be are they going to get capped at the 3% because they're going to be the highest HCC in that ACO? So those would be, besides the ones that you mentioned, which I think are absolutely the first level. Then you would get into the next level of questions and where should they be put and what's the opportunity? How fast can you action it?
Wonderful. All right, moving along. Next question here is, what is the most overlooked factor in designing VBC networks?
Well, I'll take that, and I already mentioned it earlier. I think it's culture. Like I think that like we can do all of this analysis and they can look good on paper, but if they don't have the right culture, the juice may not be worth the squeeze.
Yeah, so I'd just be interested to hear another couple sentences on that. Like practically, does that mean like if they're a 50 physician group, like do you try to meet as many of them as possible, get them all in one room? Like you interview some of the leaders, like how does that practically work?
Yeah, you can, there's definitely ways of understanding where they are and how they think of it. And certainly the more data you can get from them, the better. So for example, if you're evaluating a company, or sorry, a provider group, and their production level is like at the 110th percentile as a group, but yet their comp is down at the 70th percentile, they're heavy, heavy, heavy fee for service churning and churning to just
Yeah.
keep their comp up. And so changing that dynamic is going to be really, really challenging. But if you go into it and they're already talking about how to utilize their ancillaries more than the hospital, keeping things internal, recognizing that they have to move from fee for service, what's the leadership like? It's and it's not to say you won't work with those other ones, but if you have to be cognizant. We do. I should speak for myself. Very limited resources, and so we have to put those resources against where we think that we can make the most improvement as fast as possible.
And we had a follow-up question to that that you may have already covered, but unless you want to say a few more words on it, it says, how do you determine if the culture is ready for it?
Yeah, it's some of those ways that I just
Yeah.
sort of mentioned. I mean, I, I wouldn't think that there's like an actual test, although I guess you could design one. But it's sort of like feel, it's feel and conversation, and if you have some metrics on it.
Might be a good assessment to put together, huh?
Yeah, maybe that's the next thing for us, Jeff.
Um, all right. Next question here is, how do you ensure that providers and care teams trust and effectively use data insights in their workflows?
Yeah, go ahead,
Go
Zach.
ahead, Jeff. No,
Go
I
ahead.
mean, I think the number one thing that at least we found amongst our members is a lot of the transparency in the metrics that we build and what that's coming from. That's kind of like something that we noticed when CareJourney started up, you know, 6, 8 years ago, and we were just building on these metrics and building on some of our observed to expected logic. But if if you can't explain to like at the base level how this metric was built and the risk adjustment that we've done to ensure that outlier cases and docs that are getting the most advanced cases are appropriately adjusted, then if you can't explain that and show that that's part of your math, you're obviously going to have some distrust. So I think that's kind of like I'd say transparency and not black box methodologies is the best way I can think about it.
So I love this question because there was an article that I read when we were just starting this journey back in 2010 or 11, and the article said, if the physicians understand and trust the data, they will do the right thing without regard to incentive. And so that actually became a core to the way that we approached this. So when we first started, we always had we call them the pilots. And what the pilots were responsible for doing was anything that we were about ready to report out, they had to vet it thoroughly. So they had to go through it, make sure that it was right. And if it wasn't right, understand where it wasn't right so they could say, directionally, this is right. Here's going to be a few issues. But making sure that there's a high level of trust in what you put out. You only have a few chances to put out bad information before you'll lose them for good. And so, vetting what you send out, but then not once you trust it, not being afraid to send it out transparently, will really drive performance. However, if you send out data transparently that is incorrect, you might as well just write it off.
Yeah, you're going to lose them at that point.
You're
So I
going to
think
lose
that talks a lot to like spending really a lot of time on the quality checks of what you're putting out. If it's going to be used in this way of making these types of large financial decisions, that methodology certainly needs to be checked and needs to be accurate.
Yeah.
All right. We
Cool,
have time for
Garrett.
a couple more here.
Yeah, go ahead. Yeah.
Oh, I'm sorry.
No, I just wanted to ask
Next,
if we have time for another one. Yeah.
we do, we do. All right, next question is this. Did COVID have an impact on 2023?
So I think as far as trying to think back to the like from a benchmark perspective, I think we would have been past that generally. So, Reach uses benchmark years that are pre-COVID. However, some of the attribution would come from, I guess, end of 2020 to middle of 2022. So COVID may have had a sense in like people weren't having as many visits with providers, so the attribution may have been a little off kilter. That's one thing I can think of. But I think the positive to that, and why I actually like how Reach does it, is giving a 2-year attribution window, because making it that long really does correct for a lot of those low utilizers that may just kind of have a visit here and there that would align them somewhere that they don't normally see. So I think it's less of an effect in that Reach model. And then when you think about MSSP is only a year lagged in prospective, so it would just be 2022, which COVID had less of an effect on. Those are my thoughts from a pure kind of like alignment benchmark perspective. Jeff, I don't know if you had any more kind of on the ground
No,
thoughts
I
there.
don't. I think that's got it.
Cool.
Okay, we have one final question here that I think we have time for is what might be reasons to consider early MSSP renewal? In CY24, we had a significant increase in HCC diagnosis capture compared to prior years.
Answering the first part of it, so when you early renew, or anytime you renew, you essentially reset your benchmark. So it becomes like if your last renewal period was 2019, your benchmark is the prior multiple years to 2019 versus now it would become like prior to CY 2024 or CY 2025. So I think that's an important area to reflect on. So is that advantageous to you or not? And that's something you can model out. So I can't give a yes or no on that without having modeled it out in those situations, but something that could be different. Another difference as we get into these more, these newer years is a lot of the methodology changes only come into play once you've renewed, right? So like, some of these like risk score updates to V28 and whatnot, like those only starts for new and renewing ACOs. So, that's another option of like, that may be advantageous to you or not, but you do need to use the data to model it out.
One other, maybe a little bit of an add to that, if it's possible to join, like if you think that your risk scores are going to continue to go up, you may not want to actually start a new renewal on your own, because then you're just going to run into the same problem again the following year. You might look for an ACO to partner with that has a higher overall risk score, so you're not bound by that cap as much.
Yeah. There's
Yeah,
also, and
good
I
thought.
do have to check the new and renewing methodology for this, but I think CMS is splitting that cap to be only related to the growth of the condition factor. So your demographic factor of the HCC can grow as much as possible. That might only be for new and renewing, so maybe another reason to renew, but it's something we should check on.
Very good. Very good. Well, unfortunately, we are up on time here, but I wanted to thank you, Zach, and you, Jeff, for a fantastic presentation. Obviously, there's a lot here, and what's going to happen is don't worry, because we're going to send out a link to the recording afterwards where you can also get the slides. And that way you can review that and share that with colleagues and go through that with your team. And we hope that you do. But as we conclude, and again, I wanted to thank you, Zach and Jeff. This was a fantastic presentation. But as we conclude, I wanted to encourage you all to head over to bbcexhibithall.com and check out the CareJourney virtual exhibit booth there. And you can read up on them and see what they're doing. Obviously reach out to them through there. And there's also a robust archive of resources in the VBC Exhibit Hall library, including where this webinar is going to be archived. So feel free to check that out. And then finally, if you would like to reach out to the CareJourney team directly, feel free to do so here. Let's see, Zach, you'll go to that last slide, then think we've
Yeah,
got
and the reaching out to the CareJourney team, I think I've been told that maybe the chat functionality is not working as totally expected. If you want to take advantage of that offer, you could type in the questions real quickly, and we'll be able to record that. But this slide also gives you, and I think Garrett's going to go through
sure,
email for
sure
us.
thing. Yeah, definitely. Yeah, if you wanted to get that tool, feel free to reach out either to info@carejourney.com or through the questions, or you can reach out to me. I'm happy to facilitate an introduction. There's a lot of roads that lead back. So, but thank you all again so much for joining us and spending your afternoon with us today. And again, for a fantastic presentation. Hope you join us on the next one. Have a great rest of your afternoon. Bye-bye now.
Thank you, guys.
Thanks, everyone.